Hello, everybody. My name is Dr. Gunnar Elke. I'm a consultant at the University Medical Center Schleswig-Holstein Campus Kiel in Germany, and I'm going to talk to you now on nutritional aspects in the COVID-19 patient for the next, hopefully 10 to 12 minutes, pretty short standard presentation. So these are my conflict of interest. So the COVID-19 patient has certain nutrition relevant entities. So first of all, we have seen that most of the patients are usually older, comorbid patients, have pre-existing type 2 diabetes with a higher incidence of pre-existing malnutrition and probably worsening due to prolonged ICU length of stay. COVID-19 presents like a sepsis-like multi-organ dysfunction syndrome in its severest form and potentially dys or even overproportionate catabolism. Patients have frequent gastrointestinal GI symptoms as an early sign in up to 50% of the patients, with loss of sense of hearing and smell, nausea, vomiting, diarrhea, and GI bleeding that could all influence the way how we feed our patients. And the presence of the ACE2 receptor, the SARS-CoV-2 ACE2 receptor, is present in oral and GI epithelial and mucous cells. So when it comes down to the so-called guidelines on medical nutrition therapy in COVID-19 patients, we do have only expert statements published by the European Society of Enteral and Parenteral Nutrition, and the same by the ASPEN, so the American Society for Enteral and Parenteral Nutrition. And we actually don't have specific evidence on the effect of different MNT strategies in COVID-19 patients. So again, we are only faced with expert statements. But I do also think that we can extrapolate the most recent European and also the German nutrition guideline for COVID-19 patients. And I'm going to address, let's say, a potpourri of all these guideline recommendations for you now within the next 10 minutes. So malnutrition and COVID-19, the most severe cases of COVID-19 were found in elderly patients with pre-existing either immunosuppression, coronary heart disease, type 2 diabetes, and obesity grade 3. So all, let's say, related to metabolic syndrome entities, and also hepatic and oncological diseases. These patients do have frequent energy protein malnutrition or even sarcopenia in this age, and a likely higher potential for ICU-acquired weakness during their prolonged ICU stay. Siddiqui and Mehra just published a schematic disease course of COVID-19 patients, and you can see that it's actually quite equal to the so-called acute phase, which takes place within the first week of ICU stay, and following by the post-acute phase after day 7 with highly inter-individual differences. And then they divided the COVID disease process in 3 different phases that are followed by either admitting the patient to low care and wards or even high care intensive care units. Onset of infection in phase 1 usually has only mild symptoms, but already, as I said, gastrointestinal symptoms. Then patients progressing in COVID-19 disease enters the so-called pulmonary phase, which is divided in 2A and 2B, with shortness of breath either without 2A or with hypoxia 2B. And then when the patient's or the disease even more progresses and gets worse, patient entering the state of ARDS, sepsis, shock, and multi-organ dysfunction syndrome. And you can see that, let's say in phase 3, there is a true cytokine storm hyperinflammation, as we know from, let's say, sepsis. The ASPEN has published in their statement paper an overview on potential medical nutrition therapy aspects during hospitalization. So you can see the setting from normal ward over the ICU up to normal ward, hopefully again, and rehab or IMC. You can see the oxygen or ventilation or other intervention therapies in the table on the upper part, and also the ongoing organ failure the patient could present with. And let's say, to sum it up, you should definitely screen for malnutrition in all patients, but especially in COVID-19 patients because of the high frequency of malnutrition. You should ideally prefer oral feeding as long as the patient is not intubated, or then enteral or PN if indicated. You should, as in all critical aid patients, determine calorie and protein target, and use in ICU patients early EN to reach calorie and protein target. And that's important according to metabolic tolerance. You should also include in your calculation the lipid and calories coming from propofol and citrate renal replacement therapy, and of course, very important, mobilization. Otherwise, you can feed your patient as long as you want, but you should also try to mobilize him. And once the patient has recovered, you should evaluate him for presence of dysphagia and see if oral feeding is already possible again. Otherwise, you should supplement the patient with enteral or parenteral feeding. And again, let's say state-of-the-art post or even intensive care management, of course, for all these patients. So I think for the sake of time in this topic, I'm only going to focus on setting the caloric and protein goals, so macronutrients in the acute phase and post-acute phase of the patients. And let's say recommended is to measure ideally energy expenditure by indirect calorimetry. If I know mostly unavailable still in many ICUs, you should use simple formula in non-obese patients with BMI below 30 kilograms per square meter. And we recommend to use 24 kcal per actual body weight per day in the acute phase. 24 is recommended by the German Nutrition Society, because when you feed the patient continuously over 24 hours and you have a 1 kcal enteral nutrition solution, it helps you calculate your milliliter per hour rate of enteral nutrition quite easy. But of course, you can use a range of 20 to 25 kcal per kilo. And then we recommend that you could increase your caloric intake up to 36 kcal per kilo actual body weight in the post-acute phase, although the evidence is quite low on that. But as long as you're respecting the metabolic tolerance of the patient, I think you can increase confidently up to that range. For obese patients, you should calculate ideal body weight by the so-called Peterson formula, based on a BMI of 22 kilograms per square meter. And you should forget about complex formulas, because they actually don't make sense. I said that you should also consider so-called non-nutritional calories when you sedate your patients with 2% propofol at an infusion rate of 20 milliliters per hour. You give your patient 48 gram fat per day, and as 10 kcal per 1 gram fat, let's say, leave you in this infusion rate at about 500 kilocalories per day. Then when the patient is on renal replacement therapy and you're using citrate anticoagulation, citrate has 0.59 kcal per millimole. And when you're using a citrate dose up to 6 millimole per liter at a blood flow of 100 to 120 milliliter per minute, you end up again with around 500 kcal per day. And let's say, quite easy, that's not a bad medical nutrition therapy already. A scenario worth thinking about is that you take your ward round and you present to the professor that your patient is fully fed, 70-year-old patient, 3rd week in the ICU after COVID-19. He's tracheotomized, weaning, mobilized to chair and stand, so he has entered the post-acute phase. And enteral nutrition works at 2,000 kcal per day for the last 7 days. And you think, well, all perfect, we can go to the next patient from a nutrition point of view. But when you measure indirect calorimetry, so the energy expenditure in this patient, and it turns out that the patient has around 2,800 kcal of energy expenditure, you are quite impressed that although you thought your patient is fully fed, for the last 7 days, he has made up a deficit of up to 6,000 kcals per day. So that speaks again, especially using indirect calorimetry, especially also in your post-acute phase patients. The protein target, that's quite difficult because it's differently recommended between the European, German, and American society. We, from the German society, have recommended that you should only use 1 gram of actual body weight per day in the acute phase, and you could make up to 1.6 gram protein per kilo and day in the post-acute phase. When you combine your nutrition or protein intake with a combination of resistant training, say mobilizing your patient at this simultaneous high intake. During continuous intermittent renal replacement therapy, we do recommend a corresponding continuous infusion of amino acids that should only compensate for the loss of amino acids and should be added to the baseline calorie, protein, amino acid intake as recommended by us. The ASPEN states a little bit different. During critical illness, you should use 1.3 gram per kilogram protein equivalents per day that can be delivered progressively. And important is that the target to be reached by the end of the acute phase should at every time respect the metabolic tolerance of the patient. So signs of individual metabolic intolerance are blood glucose concentration above 180 milligrams per deciliter despite an insulin infusion rate above 4 units per hour. And you should also look at plasma phosphate concentration. If it drops once you have started nutrition, you should reduce again or even stop your nutrition, make up or infuse phosphate until it's in the reference range again, and then start nutrition again, because it may be a sign of refeeding in your patient. And the caloric-macronutrient intake should be reduced, as I said, to an extent that tolerance is established again, or as I said, a phosphate supplementation is no longer necessary. The route of nutrition, shortly, which route to prefer. EN should be started through nasogastric within 24 hours of intubation. Post-pyloric feeding should be performed in patients with gastric intolerance, and no EN in patients in shock or uncontrolled hypoxemia, hypercapnia, or escalating vasopressors. Prone position per se does not represent a limitation or contraindication for EN. NIF per se also not. Be reasonable, I say, and if it's not contraindicated, head of bed elevation posture. You may use parenteral nutrition earlier in your patient because of the risk or presence of malnutrition. So already using PE in the acute phase, but again, only according to individual metabolic tolerance. And we also have given recommendations during ECMO. You can use lipids, check your oxygenator, only infuse continuously and not, of course, directly into the ECMO circuit. Otherwise, you can also use enteral nutrition as the preferable route of choice. So that I can conclude, older comorbid patients with higher incidence of pre-existing malnutrition worsening due to prolonged ICU loss, potentially higher risk of ICU-acquired weakness, often GI intolerance possible in COVID-19 patients, still lack of clinical evidence on medical nutrition effects. So we do have only existing expert statements from the Major Nutrition Society. And I have mentioned the recommended calorie target and protein target, which is, let's say, extrapolated from the general critically ill patients, because, again, we do not have evidence. So thank you very much for your attendance. Stay safe and see you soon.